I'm Supriya Bezbaruah. I'm currently the team lead for science and knowledge translation at WHO. So I work very closely with Tina and the group. In fact, I've been in this job just 1 week. Before this, I was a lead for risk communication and community engagement at the WHO Southeast Asia region. That's a hat I've worn for a long time before changing. There too, we did a lot of infodemic work. So I'm very happy to share what we've been doing. And of course, one of the things we've learned so much from COVID-19 about what we need to do and how we need to move forward. So I hope to touch on some of those. But what I'd also like to hear is all of your experiences as well. I mean, you've just heard from and she was one of the people from the first infodemic cohort, I believe, infodemic management cohort. So similarly, I'm sure all of you have a lot of experience and insights from all your work and where you live and what you do. So please do feed in, because this is definitely in the best traditions of risk communication. It should not be a monologue. It should be a dialogue. But I am starting, having said that, with a presentation. Can you see my screen now?
Yes, and I think you just need to put it to presentation mode and then perfect.
Great, thank you. So this is what Tina and Liz asked me to talk about: promoting information equity and access. Why do we need to talk about it? This is the number I picked up yesterday from the website. 7 billion, almost 7.5 billion actually, vaccine doses have been given. That's a huge number. The question is, it's such an achievement, but who have those vaccine doses reached? Have they reached those who need them most? In terms of geographical thing, we know that most of the vaccines have been in the developed world, and it's still pretty low in the developing world. Amongst people who need it most, I mean, the people who are high risk, we know, are the elderly, the sick, those with chronic diseases, pregnant women. How many of those have got them all over the world? And why have they not got them if they haven't got them? How do we address that? I just want to go this. The second point I want to make is take you through some of the headlines in 2021. It wasn't that long ago, so I'm sure you'd recall. And I tried to get headlines from different parts of the world just to show that it's not unique to any one country or one region. This was the situation in different times all over the world. As there was a surge in cases, there was the number of deaths increased. There was a shortage of hospital beds, shortage of oxygen, whether it's in Africa, whether it's in Brazil, whether it's in Indonesia. And the third headline that you said is the WHO headline, which says that 500,000 people in low and middle income countries were impacted due to oxygen emergency. I am currently in New Delhi in India. And when there was a surge here and there was a severe shortage of beds, and there was a severe shortage of oxygen and hospitals ran out of oxygen. At that point, who was it that got the oxygen? Who was it that got the hospital beds and the ICU beds that needed?
Okay, looks like we need people to mute.
Could you,
oh,
excuse
dear.
me, I think you need to mute your mic, please.
Thank you.
Oh dear.
Scott, yeah, can you mute everybody, please, except for Supriya? Great, thank you. Over to you, Supriya.
Thank you. Right, as I was saying, you know, in the situations like this, who is it that's most affected? I know, you know, in Delhi itself, there was a severe crunch and people were rushing around trying to get oxygen, oxygen cylinders, oxygen concentrators, and they were not to be had. And those that were available were, you know, at like horribly high prices. So if you were poor, there was just no way you could afford it. And at the same time, social media also went to overdrive as well, trying to help. People were sending tweets saying, okay, there's someone has got hold of one oxygen if anyone wants to help. And so there was a lot of good things coming out as well, but the disparity was accentuated in that crisis between the haves and the have-nots. And that is the issue, the lack. That's what health equity is all about, because no one is safe till everyone is safe. And it's in crises like this that show very well how important health equity is. Health equity, as you know, the definition is the absence of unfair, avoidable, and remedial differences in health status among groups of people. Health equity is achieved when everyone can attain their full potential for health and well-being. So it's, and we've seen that in the last 2 years with COVID-19. The pandemic is still on, and there's still a lot of inequity. And we as infodemic managers can do something about it. And I'm just coming to how. So health, as we know, is a fundamental human right. And inequity, health and health equity is determined by the conditions in which people are born, grow, live, work, and age, as well as biological determinants. But it's also impacted by the structural determinants, the political system you live in, the legal system, the economic situation, and these shape the distribution of power and resources. So that's where we can do something about it. And the key is identifying and reaching the most vulnerable. I talked about some of the people who are most at high risk of COVID, the elderly, those with chronic conditions, pregnant women, but also those who are at the most vulnerable often are those at risk of poor health and those who cannot have access to health resources. And they include the elderly, those who are nutritionally deficient, pregnant women, and children, and often women who often do not get access in many social systems. The poor, migrants often get dropped out of the formal health system for a variety of reasons. How can we ensure access to health? And it's in everyone's interest that they do so. This has been recognized because the first component of the Sustainable Development Goals for achieving universal healthcare involves ensuring that people in need of promoting preventive, curative, rehabilitative, or palliative health services receive them at sufficient quality. So the issue of health equity has been addressed at the level of SDGs as well. And just to give you an idea, and in the last session, someone showed a very nice slide that made out of it. So when we talk about, ensuring health, if it's equality from the point of view of infodemic management, we're talking about here, everyone, all people get the same information, the same messages. But, so you can say we're being fair, but are we being fair? Not really, because this guy has the messages anyway. He doesn't really need it. This guy needs a little bit of understanding. This guy needs a lot of explaining and understanding and talking to. And these are, if you look at equity, you can look at it from these boxes. One box for this guy, those are information messages, and 2 boxes for these guys. So you sort of help him according to his needs and a little more for this. Kofi Annan once said that knowledge is power and information is liberating. So to have health equity, we need information equity, because we need information as the first step to accessing health. Information and then knowledge, and then you move on. And particularly in the infodemics, this is relevant because infodemic is an overabundance of information, where in that huge tsunami of information and misinformation, you lose the valid information. And that affects most are the vulnerable people, those who need that information most, but don't know where to seek it, don't know because they may have low literacy and not understand what is real and what is not. They may not have access to the information in the way it's being shared, and therefore they may not know what to do. And it's critical to therefore reach out to the vulnerable people with the right information. As you can see, there's been in the last few months a number of misinformation targeting specifically vulnerable groups, whether it's specific communities, whether it's children, adolescent children, very vulnerable age, whether it's migrants, or people who are undergoing cancer treatment. These are some of the examples. Here in the Southeast Asia region as well, we had lots of, in the initial days, there were rumors, for example, of that said COVID-19 was spread by meat, and the only way to keep away from it was through vegetarianism. So butchers were not often particularly wealthy, but they were targeted, and they were often, that the community was targeted as spreading COVID, and there was a lot of stigma around it. Then, in another case, there were rumors that said that COVID-19 is a ruse. They take you to hospital and then they take away your organs, and therefore, people who would normally go to the free state hospitals avoided going to hospital because they thought their organs would be taken. They were the ones who needed the treatment the most, and they refused to go there. So reaching and empowering the vulnerable, that's what information does. It empowers the vulnerable. It's the right information for the right people at the right time, in the right way. And how do we do it? What are the tools? There's infodemic management, there's risk communication and community engagement. And there have been a lot of questions in the past couple of years. What is infodemic management? What is risk communication? How are the two different? Here are some definitions through which I hope to make some sense of it. The goal of infodemic management is to inform action by health authorities so that populations have an enabling health service and public health environment to enact healthy behaviors, so that information goes out, the right information reaches the right audience at the right time via the right channel and the right messenger in this health environment, health system environment. Infodemic management uses evidence and data. It looks at social media data, other data, and then that data can be used by risk communication to design campaigns and reach out to people and reach out to communities to lead to positive behavior change. So it's very much linked. And so what is risk communication? In public health emergencies, it includes a range of communication capacities to encourage informed decision-making, and so that they have the information and sufficient and complete information for informed decision-making, a positive behavior change, and to maintain trust with the public. Community engagement goes one step further because behavior change doesn't happen in a vacuum. It needs dialogue, it needs persuasion, it needs dialogue, it needs understanding. So community engagement is a process of developing relationships, and it's all about relationships that enable stakeholders to work together to address health-related issues and promote well-being to achieve positive health impact and outcomes. So it's all linked together. One feeds into the other. You need the data from infodemic management to move to lead to the informed decision making through campaigns for risk communication, and to build the dialogue with communities using that information, and to understand communities better through the infodemic management data. Key to all this is trust. Whether it's infodemic management, whether it's risk communication, whether it's community engagement, trust is key. And we know that, and you've heard this over and over again. It's not new. And we also know this in our personal level. We will not do anything if we don't like someone. It's as simple as that. But when you're an infodemic manager, it's that much more difficult to develop trust. What do you do? How do you develop trust? And of course, this has been covered in many risk communication things, but trust is something about when you're honest, transparent, and you engage consistently and understand in an empathetic and understanding manner with the people you're trying to reach out to. So to promote a trusted relationship between the health system and the people, we need to engage with people where they live, work, learn, play, pray, gather. In other words, in all the aspects of their lives, the whole 360-degree way of living. Engaging them where they live. You can go for door-to-door canvassing, neighborhood community meetings, talking to each individual household. Engage them where they work, while reaching out to the workplace, to the employer's workplace health education. Reaching out where they learn is you promote health literacy. Where they play and relax and chill out, essentially, that's where education through entertainment, including a lot of information through TV programs and other programs. Peer-to-peer approaches in affinity groups, where we pray. In the pandemic, faith leaders have done a great job of communicating with people and their communities. And that is an engagement that needs to keep going, because that's one of the most powerful ways people, it reaches people's hearts to the very core. And faith leaders are trusted. Then where we gather, social mobilization, human beings are social animals, and we like to have fun and get together with others. So reaching out, engaging with people where they gather also helps. So deeper community engagement will change the community and the health system at the same time. So there are different ways you can engage with the community. And we'll just go through that now. But to have an impact, we need to really have complete community engagement as partners. The first step is outreach. Outreach has some community involvement, but you just provide the information that's needed. The second step is consulting the community. So there's a little more engagement. You tell them what you're asking for and get some sort of feedback. But further involvement entails communication flows in both ways. So it's more of not just saying, okay, this is what we want to do, what do you think? But asking them a little more. And that involves slightly better involvement. But collaboration is a bi-directional form. So it's not about you saying we want to do this. It's about you sitting together and saying, okay, we need to achieve this perhaps. What do you think? What do you think we need to achieve? So starting right from the goal, you talk through with the community, see what their feelings are, what their points of view are, which may be quite different from what you think it is. And they will come out with the solutions based on their lives. And the final one is shared leadership, which is a strong bi-directional relationship. And the final decision-making is at the community levels, and entities have formed strong partnership structures. And a best practice is a community involved in decision-making for health is more likely to own their whole health promotion activities. So if people decide what the issue is and what the solution is based on their own experiences and lived lives, they're more likely to follow through. So that's a win-win situation for everybody. And so how do we plan for better community engagement for that leading to that ultimate goal of shared shared practice, shared involvement, so to say? First is we think and we understand the community, we understand the health system, also that they are working, living in. What kind of health system do they have? Is it private, public? Is it accessible? Is it not? What is their preferred health system? What is the level of trust in the health system? Who are the influencers, decision makers? What are the dynamics in the community? Then plan. Again, you can plan with them, develop strategy, plan use of resources. What are the potential opportunities and what challenges there can be? Then again, in the spirit of partnerships, you can develop messages, choose a call to action, and identify the messengers and the channels. And finally, act. Learn from the others, build loops into the rollout process, feedback loops into the rollout process to correct course if things are not going the way you want, and share ideas for future approaches. And finally, assess. Again, I say finally, but assess should be also throughout. Monitor, measure, evaluate, capture lessons learned, prove the value of the efforts. And all of this you can do together with the community as a joint effort. And this brings community voices into the health system in a systematic, sustainable, and evidence-based public health practice. Some of the ways infodemic has been addressed amongst vulnerable populations across the world. I'll just give you a few examples. In India, misinformation has been rife, but mainly through encrypted social media. It's, as you know, one of the largest markets for WhatsApp. And this means that health officials may not even be aware of rumors that are spreading and affecting people's behaviors. So it was decided that community healthcare workers, they're known as ashas, which also means hope in Hindi, in addition to their other health responsibilities, also manage misinformation. And the way they've done it is form with their communities WhatsApp groups. So the picture at the right, I chose this picture, and I got this from this magazine called Verb. And it shows this health worker walking through forests. They often walk 6-7 miles through forests to reach the villages that they have to reach out to. And there's no road, nothing. And in the rainy season, it can get really bad. But in those remote villages as well, people still have smartphones and there's connectivity. So they receive WhatsApps. Even if it's one member of the family who has a phone, they'll be getting WhatsApps, which they'll then share with other members of the family. And that because they're so remote, that's their source of information, and they believe it in a lot of times. So the ashas then, through the WhatsApp groups, find out what rumors are spreading. So when they go, they explain to them what the facts are. In the article I was reading, this lady was talking about an old 86-year-old woman with symptoms of COVID who hadn't reported it. And she said, and she asked her, why didn't you report? I had given you the information. And so lady said, no, I got messages on WhatsApp that if you just pray and drink water, COVID-19 will then you'll be protected from COVID-19, water and lime juice or something of that sort. So she had to explain it. So their community healthcare workers have a great role in addressing infodemic amongst vulnerable population. In many countries, faith leaders have come together and spoken in one voice on COVID-19. This was essential for managing stigma because there's been a lot of violence especially in the initial days against specific groups for the spread of COVID-19. Healthcare workers have also been targeted. So because different communities were targeted, if faith leaders of different denominations speak with one voice, it creates a very powerful message that all faiths have to work together to mitigate the impact of this pandemic. Then another example I'd like to talk about is village health volunteers in Thailand. Village health volunteer program in Thailand is very famous. They have people from the villages who are volunteers, so they're part of the community. They work closely with the community for health issues, and so they know, when something is not right in the community, and they're also trusted. So they played a critical role in preventing COVID spread by providing information on symptoms and what to do and where to go. They also were critical in providing mental health support and ensuring people report when when they have symptoms. And that sort of infrastructure makes a difference, especially at the community level. So I spoke about how infodemic is managed, and how online spread of the infodemic can be managed and sort of addressed through offline ways, because although we get it online, we often feel more reassured by offline face-to-face contact with people we trust. Now, how can we, as infodemic managers, address the dimensions of information inequity and mitigate the harm? Since we're talking about this whole point is about inequity. So inequity due to disability, gender, age, economic background, ethnic background, education. So some examples of infodemic insights. So for disability, we can look at search engine optimization, metadata tagging, website analytics, whereas the risk communication and community engagement strategy, again, goes hand in hand. We look at websites and social media presences accessible to persons with disabilities. And there again, you can checking those websites, you can use the infodemic insights of website analytics, metadata tagging. So it goes hand in hand. Then gender, again, we have gender stratified data on technology use and information seeking. So you know how well women are getting information through social media and through digital media, and use RCCE to strengthen healthcare provider ability to address misinformation, as I've just told you in the previous example of the healthcare worker from India reaching out to remote communities, elderly women. Then age, you have messages, but are those messages resonating, say, with the elderly or with the very young? So you need A/B message testing, you need usability testing. Then from the RCCE point of view, say for the elderly who may not be onto social media, who may not be comfortable with smartphones or the computer, you promote non-digital method of social inoculation and information sharing, such as through community radio. Then for poor people, economic disparities, you have infodemic exposure surveys, infodemic diet report, and from the RCCE point of view, you promote free access to credible health information. You ensure that people do get it in ways that they can access the information easily. And then finally, this ethnic backgrounds, you understand them through social listening, digital observation of image and video-based content. And for RCCE, you leverage trust through culturally relevant ways and communicate through accepted media. Education, you focus on gamification, skill building for infodemic insights, and for RCCE, you have a dialogue with communities. So here, both go hand in hand. You have skill building, gamification, as well as dialogue. You have social listening, as well as culturally relevant ways to communicate, such as community local singers, local actors. In fact, earlier today, we had an EpiWin science communication webinar that spoke about getting science to communities in Africa through local singers and artists. So do go on the website as well and check out the video. It's on the EpiWin YouTube channel as well. At the end of the day, it's a partnership. How can we address information inequity? Through partnership. Of course, you need to develop high quality health information, but you need a wide network of partners to amplify the message in a sustainable manner. So when we're talking about partners, we're talking about partners from communities, we're talking about faith leaders, we're talking about youth networks, we're talking about various partnerships. And that partnership is critical and is the foundation for long-term engagement, long-term trust building, long-term amplification. It's for sustainability and to ensure access to health. You need these partnerships. Trusted messengers. We talk about trusted messengers, but who you trust may not be who someone else trusts. So it's critical to understand who is trusted in which community. It's not one size fits all at all. And finally, RCCE and infodemic management approaches are complementary and support each other. And that's critical for it to grow, especially as we enter an era where infodemics will probably increase as more and more, as the world very rapidly goes digital. Finally, one of the key assumptions we have that branded health messages are the most effective. When we're talking about building trust, we're talking and managing infodemics, ensuring people have access in the face of a flood of information. We feel branded content will stand out as a credible source, whether we're talking about Ministry of Health or WHO or any other audience. Or branded content is only credible if the audience finds the brand credible. And in many communities, not all communities see health authority as trusted and credible. You might have certain communities that do and certain communities that don't. And sometimes, therefore, pushing only the health authority may not work. So it's important to have as many trusted and credible people speaking up, or organizations speaking up as possible, especially at the local level. An infodemic manager may suggest that trusted messengers be identified from data, not from anecdote and opinion, and that's critical. So we need to know who the trusted person is. We need to learn as much about the community, understand as much about the community, and do it through data, not from anecdote and opinion. This is how infodemic manager can make a difference. And again, using data to understand the community, we can have accurate messages which meet their needs, and that will help gain credibility depending on who shares it and how. Set your messages free and encourage people to tailor remix fitted to their needs. So here are some resources that you can use for health equity and information equity. And I hope that was useful and at least has given you some food for thought. As I said, this is one perspective. It has been a monologue, but I hope it won't be. I would love to hear about all your experiences, so please do share. Thank you very much.